Hey y'all, just a heads up that this conversation includes topics like physical and sexual assault, murder, and graphic description of a medical scenario. I hope you enjoy it as much as I did. Welcome to The Long Defeat. Today we have Dr. Ed Farrell. He's worked in family medicine for 30 years in various capacities, both at Colorado Coalition for the Homeless and Clinica Family Health. He's worked in the clinical setting, seeing patients, and in administrative roles like medical director, and he's deeply committed to training up the next generation of physicians. He's made a big effort to have medical students, residents, and fellows have a bigger presence at CCH where they can get some truly unique and invaluable experience. Thanks for joining us, Dr. Ed.
Delighted to be here. Thank you, Marshall.
Of course, of course. Ed, I think you have a pretty unique perspective as someone who's been working in this setting for a long time, and caring for people experiencing homelessness. How would you say you see the suffering of people experiencing homelessness as a physician?
Well, Marshall, it's profound. And, one line that will always stick with me is that trauma is often the cause, but always the result of being homeless. So folks,
Yeah.
have suffered so much on their journey towards being homeless or experiencing homelessness. And then it's so traumatizing once people have landed there. It's traumatizing because, society does not treat them well. And horrible things happen to folks. We're going to go deep and heavy and real instantly. Some people have had gasoline poured on them and lit on fire. People get murdered on the streets. We had a horrible spate of purposeful murders in many, many summers ago in Denver. With unspeakable ongoing acts, and people were being killed only because they were experiencing homelessness. They're vilified for perhaps the way they look or just being in a public space. And I also think that it's so hard that once folks land in homelessness, it's so much harder to get out than to prevent it. And that is a form of profound suffering. And Marshall, what really happens is just mind-boggling is as one gets to know anybody who's experiencing homelessness, virtually every person, you peel away the layers of the onion and you learn what's deep within them. And there is humanity, caring, and love for virtually every person, just as folks who haven't experienced homelessness.
Yeah. I think a helpful tidbit from the beginning there is the trauma both as a cause and a result of homelessness, experiencing homelessness. We see things like mental illness overrepresented in the population that you work with, and we see people from all stages of life, from all backgrounds. I've seen people in their late teens experiencing homelessness to people at the end of their life experiencing homelessness. And I'm sure, obviously, with decades more experience than me, you've seen the same. And you've also seen them in a variety of settings as well, from doing what you do on a weekly basis, which is go out and see people where they're at, seeing them on the streets, seeing them in the health center. They come to meet you. You've seen them at the Recuperative Care Center, which is now certified as a National Medical Respite Center. And I was just wondering how those different settings that you see people in, not so much getting into like the clinical mindset that you have, but how that, or even, prior to working in these outpatient settings, maybe seeing people in the hospital as another setting, maybe that you've seen folks experiencing homelessness in. But how have each of those different settings given you a peek into their suffering in a different way?
We know, wow, Marshall, that is, as usual, plenty to unpack there. So I appreciate that about you. I think I'll start with the work of delivering healthcare on the streets.
Yeah,
Where
please.
we literally go to the people, and other folks in the country are doing street medicine as well. But the, the obstacles that people face are so profound. And, there are lots of folks who, this is once again, it's all such sobering things to talk about. And then I think I'll move from that to some inspiration, hopefully, is, that women who are suddenly on the streets of Denver on a Friday night,
Mm,
and a lot of them might be fleeing domestic violence. Um, some of them might have lost their job and couldn't, they were living paycheck to paycheck and they got evicted. And there they are in the streets of Denver. And I've met women where they say, Dr. Ed, like, I was there at 10 p.m. on a Friday night and I had to stay awake because if I didn't, I could have been at risk for sexual or physical assault. So I used meth and I'd never used it before. And they use it 2 or 3 nights in a row. Hey, the way drugs have flooded this country, they're cheap, they're everywhere. They're often, laced, if you will, with fentanyl. We've all heard about the opioid epidemic. And all of a sudden they have 2 drug addictions and had not had that previously.
right.
I think the thing that, Marshall, that you brought up is that I think that this metaphor is really important because we need to name that folks who are on the streets have a higher incidence of severe persistent mental illness than folks who are not experiencing homelessness. Yet the metaphor that really works is, hey, we have 10 musical chairs and 10 people, and they're just walking around the chairs, and one of the chairs is taken away, and there's going to be one person. But when the music stops, there is no chair. And so guess what? That's what it is with our housing situation. That we don't have enough housing units. We're short tens of thousands of units of low-cost housing in Denver. And when the music stops, of course, the people who are most vulnerable with head injuries, depression, mental health, on the edge with their labor skills, they've lost their job. Those are the folks that end up without the chair, without the housing, and they're on the streets. But and I've been very fortunate, and it's a profound gift for real to work in all the settings at CCH where we try to meet people where they are, on the streets, in the shelters, in housing, in the clinic, in the motels that have been a good thing for folks, and in our recuperative care center with 75 beds for people who we like to say they're not sick enough for the hospital, they're too sick to be on the streets, they might have wound care issues. We see a lot of folks on the recuperative care center. We had kind of like teeny tiny quasi respite care way back in the day, with collaborations with Samaritan House and Denver Rescue Mission. And here's what we see, which is just unbelievable. And I've called it, kind of gets people attention, the paradox, the gift of a broken leg, or of a lower extremity infection. Folks need admitted to the hospital. They get life-saving, amazing care at one of the area hospitals, frequently Denver Health. And then they end up in our recuperative care program. And, Marshall, this from working in recuperative care. Some of these folks come in, they've got a cap on them. They won't be able to do any eye contact. Their answers will be short and not engaged. And we just meet them with clinical expertise. Really what we meet them with, and this is what matters, is we meet them with love and care. And we treat them with deep humanity and dignity and respect. And this hasn't happened to some of these folks in years. And the next thing you know, you see them 3 days, 5 days, 1 to 2 weeks later, and they are opening up. Frequently, they're sharing very difficult things and traumas, and we can help them with that, with counseling. People have depression, anxiety, severe persistent mental illness with medications, but especially with, honestly, of course, with limits and boundaries. You can't be recuperative care if you're not getting along with the community. And here they are in the community, getting their meals, interacting with us, and all of a sudden, their personality brightens up, they shine through, and we are all blown away by what we get to witness. And the miracle is, the small miracle is that we cure their lower extremity infection. The big miracle is they become new people.
Yeah. Yeah, that's beautiful. I think, part of what you're mentioning there and meeting people with humanity and treating them with dignity, that's what I think my job is as the medical assistant. Obviously, it's to make the clinic run smoothly, but also it's such a unique opportunity for me to meet these people who our society often ostracizes and persecutes in one way or another. I get to treat them with humanity, and I may be the first person to do that in a while. And that's while I get to help you provide care to them, or help a behavioral health clinician or a psychiatrist provide care to these people. I can't do that myself, but I can treat them with dignity and respect in a pretty profound way. And that is one way that I see my role as the medical assistant in entering into this suffering that they're experiencing. But how would you see your role as a physician in relation to the suffering experienced by people experiencing homelessness?
I love that question. And, I am going to just do a quick aside here. And it's that the integrated health team, from reception and front desk and medical assistant and nurses and case managers, and everyone, we know that that's kind of like the frontline first
Yeah.
people meeting. Like, I cannot emphasize enough that what you do and what every one of those people do makes the biggest difference. I have patients say, "Oh my gosh, I saw so and so at the front desk, and they are always so kind to me. And this place helps me feel like I'm at home." And I probably have less to do with a lot of that than the medical systems and the front desk and everyone all around. And that's one of the beautiful things about CCH. And then I think, in terms of the suffering, I mean, like I think that's one of, like, the prime directives of being a physician, is to,
Yeah.
uh, to be kind always, heal when we can, and alleviate suffering whenever possible. And I think there's the usual kind of ways that the physicians and NPs and PAs and any healthcare professionals look at that, and that we can do that with medications to help with depression, pain, to help someone's diabetes be less in control of their life. So all those kind of medical things are huge. The interventions are huge, including the kind of, frankly, the miracles that can happen in concert with, specialists that we interface with so many people. I think about this woman who had lancinating facial pain, who was experiencing homelessness years ago. and I got her into the pain clinic, and she was on a very unusual treatment regimen for this trigeminal neuralgia, which just is famous for causing severe pain. And this medicine was a miracle for her. She'd been suffering for 5 years. So there's like the medical treatment and the mental health treatment of conditions. But I also think that, you know, this line from a therapist that I was seeing uh, when journeying with my kids decades ago is all healing occurs in the context of personal relationship. And sometimes that's all we have to offer. We are journeying with and for the person to the best of our ability, and we are treating them with dignity and respect. And you know what? They have an untreatable progressive cancer, but we are there for them wherever they might be, where CCH sees folks. And I think that that is a really important thing. And to, ask people, well, how are there ways that we can help? To allow people to give them space to talk about whatever it might be that is causing them to suffer, including, I don't do this all the time with everybody, but if, a lot of times people will open up about their faith life, their support, I'd like to get to be with my brother. I'm sure have seen this, that people, for the first time, they want to get in touch with their mother in Georgia. I have a patient who's in better touch with he's in the tiny home community. He's in the better touch with his sister in Connecticut. So all these little things add up.
Yeah. And I mean, one more way that I've seen you enter into the suffering is going above and beyond in a way that I aspire to advocate for people and work with the city and different committees in the city. There's one patient in particular who passed away last year that I'm thinking of, that I'm sure you're probably going to be thinking of shortly, that I saw you just pull strings and work so hard to get him housed. And then miraculously he got housed. And that is something I aspire to do, is to go beyond the walls of the clinic to help alleviate the suffering, in whatever way that is possible. And in thinking about what that therapist said, that all healing happens in personal relationship, I think that begs the question then, because it's all happening in personal relationship, then that suffering that you are seeing, that these people experiencing homelessness experience on a regular basis, daily basis, hourly, or however you want to think about it, that must affect you as a physician, as an individual. How have you experienced suffering by making yourself close to the suffering of others?
Mm-hmm. Such a great question. And and usually you'll mention one thing that will get me to something that is a squirrel from the from your question at the moment. But from listening to you talk about that patient who was so just a wonderful man.
Yeah. Yeah.
And somebody said the other day, I forget the forum, it was like, well, we're not supposed to get attached. And I'm like, if we're not getting attached, I need to find a different job.
Yeah.
I need to care deeply. I need to be attached, yet to have great boundaries and to have, but to journey with people in a meaningful way. Of course, we're attached.
Yeah.
And then I just thought about this line from this famous German physician, not to go medical. There's a lymph node right here. When people have swelling of this lymph node, it can sometimes be a sign of gastric cancer, for example. This guy's name is Rudolf Virchow, and there's a Virchow's triad. Anyway, the thing that people don't know is he was a tremendous advocate for healthcare for all. And his line is, you know, physicians are the natural lawyers for the poor. And what I would like to say is, back then people were thinking physicians, but I'm always thinking like all CCH staff
Yeah.
are natural lawyers for the poor, and we all do it. And with that gentleman, it was a gift to see him get housed, and it does break my heart that he passed away. And it's at the same time, it's beautiful that he got housed, and he turned into a bright light of a personality while he was housed. And then I think that I'm telling you, it's your question about like how have I dealt with the suffering and what do we do as we witness that? How do we cope? I was on street medicine yesterday. I was with a resident physician. I won't say exactly where we were, and and we were near highways and so forth, and we were kind of in between things. It was a team. As always, the medical assistant, the nurse, mission critical, and I think she was being emotionally moved by, this is just rough to see, and that's the experience people go out, I think, and she said, well, how do you cope with it? I don't. It's an interesting thing. It's a hard thing to answer because we witness moral injury where, because people are getting truly discharged to the streets with no socks.
Yeah.
Or I saw someone a week and a half ago who they said, okay, we're going to admit you and take out your kidney cancer. And they said, oh, your insurance doesn't cover it. You'll have to pay $35,000. Write a check for that clears before we can treat you. And it's brutal.
Yeah.
And we got to be real with it. Can't sugarcoat it. We are, I think that every human deserves health care, housing, and being treated as a human, people respecting their humanity. Like it's the 3H club. Healthcare, housing, humanity. And it's hard when we don't see that. I think that for me, one, we do see these remarkable miracles as mentioned above with the people who we do see the people transition from scared, closed, not open to their leg or their wound or their medical conditions get improved and they get housed. And you know what? We've got to celebrate that. And I think number two, we just gotta keep on hanging our hat on. Sometimes all we can do is treat the person right here, right now, as though they're the most important person in the world. Dignity, respect. And, I've had times when people tell me they found out they had cancer and they're going to stop the treatment. And we shed tears together.
Yeah.
And I think third, there is some solace and, just maintaining hope that, one person at a time or with systems change. And we see systems change and people and systems become more open than they used to. And for sure. And there are amazing people everywhere who are of the same mindset. And together we can make a difference, and we do.
Yeah. Yeah, I think that I want I plan to end this conversation, in a few minutes, on a hopeful note, and it is helpful to have these nuggets throughout because I think this is the first episode of the podcast, and I think deeply about this kind of thing and talk with you about it regularly. And it is hard. It just is hard. And the work we do is hard. And I remember still the first patient that I had cared for, who died, and I remember the first time I cared for her and did her wound care on her feet, and I was like, this is washing feet. This is what Jesus was talking about. Even if I'm not a particularly religious person, um, that was a profound experience for me. And I remember also this individual had severe persistent mental illness and was determined by the system, by the state, to be able to make her own decisions, and she could not. She could not. She was late in her adulthood, somewhere in her like 60s, but couldn't tell us her name, couldn't tell us her birthday. She thought she was approximately like 35. And this person, who clearly does not have the capacity to make decisions for themselves, is left to live on the street and dies because of it. Her diabetes progressed to the point of kidney failure, and she died in the hospital. And reading the note from the nurses who were there when she died, like she did not, she was in distress to the very end, and that
Ugh.
is heartbreaking. This is just a very hard reality of the world we live in today, and I remember I remember one of our colleagues telling me, when I was just expressing so much frustration about her situation and everything, he was like, "Don't lose this." He said, "Don't lose this," because it's really easy to get jaded, and to see enough of this that you just take it for what it is, and you stop caring and you stop trying to make things better. And I guess I just would like to let you riff on that if you could. Have you had those moments in the last 30 years where you're like, man, is any of this worth it? Is it any of this doing anything? And how do you get yourself out of those ruts, if you will?
Marshall, that's an amazing story. And it is so in the marrow level or DNA molecular level, it's so unjust and so, and to quote Mother Jones, if you're not angry, you're not paying attention.
Yeah.
And so, I do think that, we have to, I mean, there can be utility to that, that can inspire us to, gosh darn it, we've got to change this. And I think that at times has motivated me to get things done for patients, to like name truth. I was trying to consult a hematologist the other day, and, wow, that patient's not in our county. They need to ask the other hospital. Notice I'm not naming the hospital. And I was busy and it was complicated. I just said to the nurse, it's like, I just hope that you'll tell this physician that if any of the physicians from that hospital call me up and say, we've got a patient here I want to talk about, we're always going to say yes. And that they should, for people working in the trenches doing this work, next time, please talk to me for 3 minutes and then tell me that you can't talk to me. I mean, I just was flabbergasted at that. So, and I do think that this washing of the feet is an incredibly powerful metaphor. It's so humbling.
Yeah.
And it's really humbling for the person whose feet are being washed. And, we think that we're delivering this service, but they're kind of giving up their like soul and their freedom to like allow us to. I think it's this lens, and honestly, I've had a lot of times where I'm like working on folks' feet in whatever way, shape, or form. And it ends up being this like kaleidoscopic prism into the beauty of them.
Mm,
They end up
yeah.
sharing things that can be pretty meaningful and deep. And maybe two stories. I think that so I do get very disheartened at the bigger picture. And and I think a lot of us in this field, well, all of us, we get motivated to try to work for this person. But it's so disheartening, Marshall. I took care of this man who had a huge tumor. It was actually a wart for sure that was probably just short of racquetball size. And it was on his ring finger. It had been growing for about 4 years and he didn't have insurance. And he was still working as a mechanic. And he would just wrap this in a cloth and work in his tail and his hand off. And it would bleed and he would just carry on. And it was crazy to think that he could do this. And he came in and was like, well, I just realized I had to have it checked out. And I saw it and thought, darn, I'm worried that this has turned into a cancer. Sent the referral to the hospital. It wasn't Denver Health. And, and they denied it and there was a picture with it. And so I called up the clinic and talked to the doctor. And he said, okay, we'll get him in. And even though he doesn't have insurance. So I was able to advocate and agitate. And they got him in. And they had to do this resection all the way of his ring finger, all the way they took about half of his big bone in the palm of his hand, his metacarpal. And it was cancer. And they cured him. But that's not healthcare justice.
Right.
That's like squeaky wheel gets the grease. And that's not what we want. And that's really frustrating. And I think that we keep on hoping that we can move hearts, change minds, and and that people can be progressively more open to, what, this referral's coming from you. There's Dr. Kirkpatrick, gastroenterologist at Denver Health. He said, look, when we get a referral from you, like, our job is just to see them.
Yeah.
And that's what we need to do. He's, I don't think he'll mind me quoting him. And, he's a little bit my senior. And he's like, well, I don't know if everybody else feels this way, but our job is just to see the patient regardless. And I think that's the clarion call. And if we're in a system where that's not the case, well, we hope that we can advocate for that. One patient at a time. Good old Paul Farmer. People thought he was, how could you possibly be taking care of this much care, this much expenditure of resources for this one person from Haiti? Well, guess what? It makes it so clear that everybody from Haiti deserves this care.
Mm.
And I think that's what we can do. And maybe I will close with a kind of an amazing story. If you ask me, I was on, if we still have time, Marshall Power.
Absolutely. Please, yeah.
So this gentleman, we were on Street Med, and we were heard like, oh, we got to go see this gentleman on Street Medicine. We were looking for him, and I'd never met him, and we found him. And it's like, oh, there he is, and he's in a wheelchair, and he had bilateral, both sides, toes amputated, and he hadn't had his dressings changed in forever. So I started to, with the nurse, we started to try to remove the dressing. It was kind of stuck and congealed to where the wound was. And I just said, oh, this is a big deal. I don't think we can do it here. He was like, I don't think we can do it here. I was like, this is great. How about if we wheel you to the clinic? And so we brought him up to the second floor to where the foot basins were. This story isn't for the faint of heart. And so we did it there with the water and, little saline to loosen things. And we're with a nursing student and the patient, as we slowly removed it. I think, Marshall, you might have heard this story, but she just gasped. Excuse me, the patient gasped. And the nursing student had the most brilliant, beautiful, trauma-informed care, treating everybody as though they have experienced trauma. Line, oh, sir, don't worry. Those are helping make sure that your wound stays nice and clean. Because there were a whole bunch of maggots that were washing down the sink. And she was right. It was like the best line. I love this. Working with nursing students who are like, man, I think that was a better line than I could have come up with. And he was like, oh, okay. And then guess what? We got him into a respite bed. Then we wheeled him up to the second floor of respite and he got admitted. That housing situation didn't work out that time, but we got everything healed up. And this gentleman I heard is successfully housed now and doing well. And I just think that's what keeps you going, despite all evidence to the contrary that, we should be throwing in the towel.
Yeah. Yeah. It those little successes are definitely what makes this work seem sustainable to me, right? If it was just the hard stuff, I think I would become so disheartened that I don't know if I would want to go to med school. I don't know if I would want to move forward into this suffering. But to see the little wins is so heartening and so um, encouraging, and makes the work um, easier to tolerate when it's hard, but the hard stuff makes me so certain that that's the reason I'm there. Um, and yeah, I think, we talked a little bit, or you talked a little bit about uh, how the Denver Health gastroenterologist, Dr. Kirkpatrick, is, and we've had this conversation I'm about to introduce here in the past, about how I think about one of the really profound opportunities that CCH has, which is to move the needle, even just in small ways. And the reason I'm thinking about this now is because we also have a nurse, an RN, Annika, who's moved on from respite and now works in the GI clinic at Denver Health.
Oh, right,
Um,
right.
she's awesome, and she has moved the needle there, because her colleagues now see her and the way she interacts with our patients. And how can you follow Annika into a room when she has gone in and treated that patient with dignity and respect and care, and then go in and be a jerk to them? That's
That's
so
right.
hard to do that. She's so sweet. It's
That's,
hard to go in and be a jerk after that.
that's right. That's right. And it is such the little things that make a difference, you know? And, there's so many other folks at CCH, like, right? Like
Yeah.
you could interview, another 20, 80 people and that my colleagues inspire me. Amazing. Everybody's inspiring, man. Seriously. I mean, we all have our rough days, but, at CCH, someone, it's like says something that's untoward, improper along the lines of, well, frickin' A, you kept me waiting so long. What's wrong with this place? A lot of places will instantly go to, you can't talk like that, or else we won't see you. And then we'll say, oh my gosh, I'm so sorry. I'll bet you're having a really rough day. Could you tell me about it? Please forgive us. And the next thing you know, they're breaking down and they're crying, and it's the anniversary of their son's death.
Hmm.
Or, they got evicted 6 weeks ago and they wish they hadn't snapped.
Yeah.
And we see this all the time that our job is to create open, caring atmosphere that respects people. And, obviously people can't be, planting, swearing F bombs, if that's proper to say on a in the exam room at us. Like that's not the point. It's how can we, you know, treat people with dignity and respect, name that they're suffering and they're in pain. And I just can't tell you how many folks I've seen. And I think I shared this with you, but back in clinic, when there were five of us providers, two nurses, Margie and Carol, my inspirations, they were there when I landed there in 94. There might have been quite a few years, might have been 16, I don't know. But they would write Ed on the chart of people who were escalated.
Yeah.
Um, I don't know. I think I wasn't bad at it. Number one, because I was drinking the motivational interviewing Kool-Aid. Two, I had a lot of experience. Three, I was blown away by how the vast majority of the time people just needed a good listening. They just needed a good listening. And here I am, I'm mentioning these names, and probably at least three people will listen to this podcast, Marshall. Just teasing. But Andrew, the RN from Respite, one of the RNs, amazing RNs, sent out an email this morning that I read pretty darn early. That it brought me to. I emailed him back, and I think people probably wouldn't say I'm very wimpy or anything, but I'm real with my emotions, and it brought me to joyous tears. His story of a person who blossomed over there.
Yep.
He said, "Listening saves lives." Unbelievable line. And it was preceded with, hey, it's not only CPR and medicines. And he told this beautiful story of this person because Andrew clearly is an amazing listener. This person opened up to Andrew, and Andrew delivered care, helped him get the care he needs. And listening saves lives. And we got that's, what do we have that AI doesn't? We can listen
Yeah.
in a way that, AI isn't going to be like with a pregnant pause. Wow, this sounds so hard. I mean, maybe it will develop that way, but I'm telling you, their AI is never going to do it with the same EQ as you or me.
Yeah.
The emotional quotient matters.
Yeah, that is so real. And I think some of the most profound interactions I've had with patients are, I'm going through the intake, we're doing these questions, and I'm just asking them about themselves, and then something comes up, and there's a switch in the room, and you can feel the energy change, and then they start to share really real things, and they start to cry, and I just pull the door closed and just sit in front of them and let them be. And sometimes I don't even speak the language well enough to get into the complexities of that, right? One of the more profound experiences I've had is just holding a Spanish speaking migrant male who was just weeping, and
Yes.
he's alone in Colorado and wants to see his family and feels alone. He feels like he's going to die alone, and I I can't put into words how to respond to that, especially not in a language that's not my first language. So it's just, I think, not leaving our humanity at the door when we go in to see them, but bringing it with us because that's our strongest tool, probably.
Marshall, that's so spot on and just beautiful, man. And I've witnessed you do that with a lot of people.
It's a man. We work in a cool place, Ed. I really, I really like it. I hope
Profound.
it doesn't. Yeah, I keep telling people this, but I hope it doesn't ruin healthcare for me anywhere else. But it might.
There's people who, they keep coming back. I had the boomerang, that was for sure.
Yeah, yeah. Um, as we're talking about moving the needle and seeing things maybe get better in small ways. The way I think about that is these nursing students, medical students, medical assistant students, fellows, residents who come through CCH get to see the way that people like you or our other colleagues do trauma-informed care, do motivational interviewing, these clinical sciencey terms that aren't altogether that important. But we get to see them take those tools now and go on to places like Denver Health, go on to places outside of Colorado, and hopefully move the needle in those places too. That gives me hope for the work that we do. What other things are you seeing, in the last, since 1994, in the last 30 some years? What things have you seen that give you hope? What things do you see happening now that give you hope moving forward?
Well, the ACA, Obamacare, I think that people are just, the general American population all recognizes this is unbelievable. It's a godsend. It's an incredible thing that happened for the country. And why any politicians are against it is very mysterious. And that gave me great hope. And I would give talks for many years, and I would keep changing the slide of how many Americans were uninsured. And the thing that's kind of weird, Marshall, is I was always having this smart aleck remark with this slide. It'd be like, I think maybe the last one before Obamacare might have been 45 million. And I said, I think the number is going to keep getting big enough that someday there's going to be a movement and we're going to, this is going to get fixed. And I said that for a long time. And I said, but I would also say, and when it gets fixed, I really hope and believe we got to take the number of uninsured to zero. Because if we take it to 18 million, which might have been the number at the time, might not have been, it's directionally correct, Marshall. I like to say, I said, if we only have 18 million, then like with 45 million and the country population was lower, then we all knew somebody without insurance that was suffering. Yeah. And if we only take it down by 60 or 80%, then no one's going to know anybody. And then those folks are going to be the new disenfranchised. And that's what happened. So it's both sides of the coin. Amazing hope, Obamacare really changed the world. And then, it's getting taken away. And, if anybody really knows anybody who needs health care and doesn't get it because they don't have Medicaid, they would understand. Oh, goodness, it's my brother, my sister, my cousin, my whomever. So I think that's number one for hope. Two, we do amazing collaborations that improve things. Setting up better connections. I have this weird thing where I make my digits go back and forth and connect. Interdigitation. So sorry. I just think it's a weird word and I like it. Like between us and Denver Health, we've improved all kinds of things. Yeah. E-consults, they're one of their folks that's inspired me, Katie Joseph, she set up a rotation at CCH. We never had an emergency medicine resident, and she's all about the trauma-informed care and helping ERs move that forward to the next level. Universal precautions. Everybody's been traumatized, and she's making amazing things happen. So we do have these beautiful things happen. I think the other example that's big is when we can help people who deserve it get on disability. Mm-hmm. That can be an entree into greater services, housing, and it's always humbling because 15 years ago we could get those types of folks into housing very rapidly. Now the housing is so much more difficult to obtain. Denver, unlike cities like Houston, Pittsburgh, the price of housing is reasonable. There's many, many thousands fewer folks experiencing homelessness in those cities where the cost of housing is low.
Yeah. Yeah, I think that is a whole another layer of the onion and a whole nother conversation about how the cost of housing is inflated artificially in places. And I've heard you actually talk on other podcasts about how construction companies are meant to build these units for people who are experiencing homelessness or people who are lower income. And then instead of because all that they have to do is pay a fine, they choose not to build those units and just pay the fine. And so the system is built to perpetuate and propagate this issue because we just have too many cracks for people to slip through. And it's a pretty remarkable place where we get to work and get to see people housed, get to see people in that could be in transitional housing, permanent supportive housing, recovery places for substance use disorder recovery kind of things. Yeah, I think, thank you so much, Ed. Thank you for the last couple of years that we've gotten to work together and all that you've taught me and all the people that you teach to move the needle, both at CCH and at Clinica and at University of Colorado, all the things that you do. Thanks for sitting through like an hour of me yapping and you yapping, and I really appreciate it. Thank you so much.
It was a joy to spend time with you, Marshall, and um, it's just so cool that you are putting together podcasts to, help all of us keep on moving the needle together, my man.
Yeah, yeah. Thank you so much, Ed.
All right, you take care.
See ya.
All right, thanks, bye.